It's a pleasure to be here today. Today is Tuesday, March 31st, and I'm sorry that we couldn't be together in person, but as cases of COVID-19 start to appear in our community, it's important that each of us does our part to maintain social distancing. I'd like to begin this morning by thanking Ashton Curry for the invitation to come and speak today. And I'd also like to thank every one of you in the audience for taking the time and the interest in learning about this unprecedented pandemic in order to offer the best and safest care to your patients. So thank you. So as I said, today is Tuesday morning, March 31st. And the reason I mentioned that, emphasize that, is because the data that is accumulating during this pandemic is so fluid and changing from day to day that I want you to have a reference point as we move forward through the talk. So this is a very busy slide, and please don't be overwhelmed by this, but just to point out that the current state, this was the current state as of this past Sunday morning, the cases in the U.S. And here in Missouri, at that point there was 840 cases in Missouri and 10 deaths. By contrast, in New York, there had been 53,000 cases and 827 deaths. So next, we'll delve into the numbers in a little bit. These are affectionately known as Dr. Fauci donuts. And Dr. Fauci donuts are being sold off the shelves right now in upstate New York. Dr. Fauci is the preeminent infectious disease director of the National Institute of Allergy and Infectious Diseases. He's 79 years old. He's held his position now for 36 years. And he is the one that, the voice of reason that stands next to President Trump when the president offers some insight onto the current state of COVID-19. In Dr. Fauci's comments this past weekend, he indicated that he thought that there would be millions of cases in the U.S. of COVID-19 and that there would be anywhere from 100 to 200,000 deaths. Keep that number, 100 to 200,000 deaths, in mind as we go forward and as I share the figures with where we are today. It's very, I think, concerning as far as the number of cases that are still in front of us. So this is a graph here depicting the number of acute care beds per 10,000 population in various countries around the world. And you can see that the U.S., shown here in orange, has a lot of beds, but there are still many countries ahead of us, so to speak, that offer and have more beds available than what we do here. The problem with Italy has been well chronicled in the news, and they have fewer beds, but we're kind of in the middle right there in that particular grouping. The other thing I want to point out is that according to this report, they do not feel going forward in the U.S. that the biggest problem is going to be the fixed number of beds or fixed number of ventilators that we have available, but rather the number of well-trained staff to care for all of these patients. And that's where you come in today. So kudos to you for getting the training here and learning more about this disease, again, so you can take good care of your patients. So with that as a backdrop, our agenda today is a busy one, as you might guess. There's a lot to talk about. We'll provide a brief introduction to coronaviruses and how past coronaviruses, the ones that cause the common cold, are different from the current level of coronaviruses. We'll talk in that context a little bit about SARS and MERS. And then we'll, in order to try to get a better handle around COVID-19, we're going to compare that infection with a viral infection that all of you know very well year in and year out, the seasonal flu. Then we'll talk a little bit about how coronaviruses corrupts not only individual cells, but also the body and what it does in the lungs and in the respiratory tract. And in that context, we'll mention a possible vaccine approach. We'll spend a fair amount of time talking about lessons from China and Germany. And then we'll talk about testing in Missouri and how that's going right now and what's necessary to have a test done. We'll talk about the routes of transmission and then the ways to prevent that transmission through the use of masks and other PPE material. And then I'll present a little something here to make you smile. Then we get into the difficult part of the talk, which is the ins and outs of the R0. This is where some of these dire predictions that Dr. Fauci was talking about over the weekend come into play. We'll talk about what went on with the Diamond Princess, talk about some of the frustrations, nationwide frustrations that have gone on with testing. From there, we'll talk a little bit about treatment, although there's not a whole lot to say about that at the moment. We'll talk about prevention and social distancing, and then a little bit about offering predictions about what life is going to be like for us here in St. Joe, as far as the number of cases that are projected, offer some additional resources, and at the end, a summary slide about the big picture. So let's get started. So coronaviruses get their name from their similar appearance to the solar corona. So you can see here in this electron micrograph in the top left that the virus shown here in yellow and red, the nuclear material, the RNA is in the center, and then the green spikes are these protein spikes on the outer part of the virus that are important in allowing the virus to get a foothold, if you will, in lung cells. So coronaviruses as a family account for a large number of viruses, and they account for about 15% of the common colds year in and year out. Rhinoviruses, as you know, are the leading cause of the common cold. But every January and February, for decades now, coronaviruses have been a very common cause of the cold. Coronaviruses are also found commonly in animals and especially in bats. And occasionally, coronaviruses from animals can make the leap, so to speak, into people, and then from there spread between people, as we'll talk about in a moment when we get into SARS and MERS. But it's this ability to adapt to human transmission that determines ultimately the duration of human infections. So again, we'll talk more about that in just a moment. But the key here is how well the virus can adapt to human transmission. That, I think, ultimately will determine how much of a problem COVID-19 for humans is going to turn out to be. So as we alluded to, bats seem to be the source of many coronaviruses, including not the ones that cause the common cold, but they, on the other hand, do seem to be the source of SARS and MERS and now COVID-19. Bats, as a rule, are tolerant of many viruses, including Ebola, Marburg, and remember, rabies virus is very commonly found in bats. They devour disease-carrying insects, and they're important for pollination purposes. So right now, when we order a respiratory viral panel, that's collected on a nasopharyngeal swab, and then the laboratory in turn tests it for a whole variety of pathogens. And some of the pathogens that they test for are 4 coronaviruses. These are the coronaviruses that cause the common cold. So please, please, please understand that when you get a positive result like this for a coronavirus, this is not implying the presence of COVID-19. This is just the cause of the common cold. That's all we're talking about here when this is positive as far as this PCR determination is concerned. Okay, oh no, one other thing here. If patients turn out to have a rhinovirus cold, they're placed in contact droplet isolation. If, on the other hand, as in this particular example, the patient has a coronavirus upper respiratory infection, normally they're placed in standard isolation. Unless their cough etiquette is not very good, in that case, then they're placed in droplet isolation. So, all right, so let's move on then to other more recent versions of coronavirus, notably SARS, which stands for an acronym standing for Severe Acute Respiratory Syndrome. So it's important as we go forward with this talk to get the terminology correct. And so SARS is the disease, and the causative virus is SARS-CoV-1, coronavirus 1. So just like with AIDS, AIDS is the disease, and AIDS is caused by HIV virus. There's SARS, and then the causative, SARS is the disease, and then SARS-CoV-1 is the causative virus. SARS was around for about 6 or 8 months in 2002 to 2003. There was a little over 8,000 confirmed cases in 25 countries around the world. It started in the Guangdong province of China. It's transmitted by respiratory droplets and contaminated surfaces, and the case fatality rate was estimated to be about 10%. What's interesting about SARS is that it never adapted very well to human transmission. And as a result, SARS petered out, if you will, after about 6 or 9 months. It went away, and it has not come back since then. One can only hope that the same will happen for COVID-19, but that remains to be determined. A decade went by, and then another coronavirus emerged, also from animals. Both SARS and MERS, they believe, came from bats, started in bats, and then in the case of SARS, went to another intermediate host animal, and then from there made the leap into people. With MERS, it appears that the virus started in bats and then made the leap into, of all things, dromedary camels, and then from there made the leap into people. MERS emerged in 2012 on the Arabian Peninsula. It's transmitted by respiratory droplets, and also it's been recovered from environmental surfaces, but there's been no evidence so far to show transmission from an environmental surface like a tabletop or a doorknob, for example, to people. Yes, it's been found on surfaces, but that's about the extent of it. The case fatality rate is a little higher than SARS, was 36% for MERS. All right, so with that, let's compare COVID-19 to seasonal flu. Now, before we go any further, let me just add here that COVID-19, that name, the disease, comes from CO, stands for coronavirus, corona, CO, and then VI for virus, and then D for disease. The 19 refers to the year 2019 in which it was discovered, so hence the name COVID-19. So the latest figures that I'm aware of, and I just updated this last night, was that so far in the US this year, there's been 39 million cases of flu, and there's been 161,000 cases of COVID-19. So vast differences in the numbers. And as of last evening in Missouri, there was 1,071 cases reported of COVID-19 in Missouri with 14 deaths. For flu, there's been about 24, according to the CDC, 24,000 flu tests so far this year. And the latest figures that I've seen were just short of 3,000 cases, 3,000 deaths from COVID-19 so far this year. The case fatality rate is a little higher for COVID-19. It's 0.1% for the flu and anywhere between 0.5 and 2% for COVID-19. The incubation period, again, let's define what an incubation period is. In short, an incubation period is that time frame from entry of the virus into the host to the onset of symptoms. So entry into the host to the onset of symptoms. Is for seasonal flu is 3 days, for COVID-19 is 5 days. So a little longer for COVID-19. The duration of contagiousness for the flu on average, if the patient is otherwise healthy, is a week. But it's important to understand that immunocompromised patients, patients who are on biologic agents, cancer patients, AIDS patients, they can shed flu virus for weeks to months. Weeks to months. The average duration of contagiousness for COVID-19 is 10 days. Patients most at risk for both infections are pretty similar. Older folks older than 65, and those with chronic diseases, immunocompromised hosts, children and pregnant women. Kids tend to be more ill from seasonal flu. Remember all the flu cases that we saw in kids at the beginning of this flu season with influenza B. COVID-19, it seems to be less common and cause less illness in children than the flu. Part of that may be due to the fact that a high percentage of children with COVID-19 are asymptomatic, and because they're asymptomatic, they're not being tested. Through vaccines, we get at least partial immunity from vaccines. We said partial immunity because, after all, the flu shot is not 100% protective. So that's why the immunity is considered partial. The duration of immunity for COVID-19, in other words, if a person has had proven COVID-19 infection, then the question comes up, are they immune to reinfection in the future? Should they be re-exposed? And the short answer to that question is a qualified yes. They would be immune, but we don't know for how long. That's the key thing. We don't know for how long. Antiviral therapies, there are several now available for the seasonal flu. And according to CDC, this year, more than 99% of all flu isolates have been susceptible to all 4 drugs. So we're in good shape there. There's currently no FDA-approved antiviral therapy for COVID-19. We're not able to contain the seasonal flu. It causes epidemics every year. Despite the ready availability of the flu shot and antiviral agents, we're hoping, with fingers crossed, that we can contain COVID-19. But it's already, as we know, already a worldwide pandemic. So how do coronaviruses do their dirty work? As we alluded to a few moments ago, the four coronaviruses cause nothing more than the common cold, an upper respiratory infection, and they infect cells primarily in the upper respiratory tract. In 2002, 2003, when SARS came along and the cause of the virus SARS-CoV-1, they infect cells in the lungs. That's what separates them from the earlier coronaviruses that just caused the common cold. MERS is the same way. MERS-CoV affects cells in the lungs as opposed to just the upper respiratory tract. And SARS-CoV-2, the cause of the current COVID-19 pandemic, does pretty much the same thing, gets into cells in the lower lungs. What's interesting too and the reason that the cause of COVID-19 is designated as SARS-CoV-2 is because there's a 75 or 80% overlap genetically between the genetic material of SARS-CoV-1 and now the cause of COVID-19. So the point is that the virus is much more, the cause of COVID-19 is much more closely related to the virus that caused SARS than the virus that caused MERS. That's the point. And interestingly enough, SARS-CoV-2, the cause of COVID-19, is able to grow actually better in human lung cells than in tissue culture cells. So this is a schematic, a cartoon schematic here of the virus. These red markers here are meant to represent the proteins, the spikes on the outer part of the virus. And then shown in yellow here is the lipid envelope of the virus. The lipid envelope is what dissolves away when you and I wash our hands with soap and water. It's the soap that dissolves away that lipid envelope and inactivates the virus. And then contained within the center core of the virus is the genetic material, the RNA. These, for any virus to gain entry into a cell and corrupt its genetic material, the virus must first attach to a receptor on that cell. It's kind of like putting a key into a lock. So again, going back to the HIV example, HIV virus doesn't infect a red blood cell, for example, because the red blood cell doesn't have the proper receptor. But on the other hand, HIV will infect certain types of white blood cells, known as CD4 lymphocytes, because the HIV virus has the ability to bind successfully to a CD4 receptor on certain T lymphocytes. And once that happens, it's like turning the lock, and that gives the virus entry into the cell. So in the case of SARS-CoV-2, the cause of COVID-19, the receptor in cells that the virus binds to is something called the ACE2 receptor. ACE stands for, just like you would think it would stand for, angiotensin converting enzyme. And both SARS-CoV-1 and SARS-CoV-2 bind to this same cellular receptor, this ACE2 receptor. That'll become important here in just a minute. Over time, with SARS-CoV-1, the virus, believe it or not, actually mutated to allow it to better bind to these receptors and optimize replication and enhance virulence. That was very interesting to see that play out with SARS. By contrast, MERS virus has not mutated substantially to enhance its infectivity. So again, that's a little worrisome here because, as we said a moment ago, SARS-CoV-2 is very much aligned with SARS-CoV-1, and SARS-CoV-1 we know is very capable of enhancing its virulence. So this is the virus now embedded in a lung cell, we'll call it. And the RNA, shown here in gray, is released. And then once the RNA is released, then through translation, viral proteins are produced, and now you've got viral RNA, you've got viral proteins, you've got all the necessary raw materials to create new viral particles. And so reproduction of the virus happens very quickly. millions, literally, each cell can churn out millions of cells of viral copies. And eventually then the cell gets overrun and dies, breaks down and dies. But each cell can produce millions of viral particles. Where do all these viral particles go? They end up either infecting other nearby cells and starting the process all over again, or they can end up being covered, if you will, in an envelope by mucus or other respiratory secretions. So they're basically wrapped, the virus are wrapped in a layer, if you will, of mucus or respiratory debris. Now, what's interesting about this is that this offers some insight into a possible vaccine approach for COVID-19. We said a few minutes ago that the SARS virus, causative virus, SARS-CoV-1, targets the same ACE2 receptor as does the current SARS-CoV-2 virus, the cause of COVID-19. So once the receptor is bound to by either virus, the virus then can gain entry into the cell. A possible vaccine approach here is that if we could design inactive SARS-CoV-1 viral particles and inject them in vaccine form and let antibodies form to that, then those antibodies would block the binding by SARS-CoV-2 onto that ACE2 receptor and prevent viral entry into cells. So that may be a possible vaccine approach going forward over time here. We'll see how that plays out. One of the questions that frequently comes up in these discussions is, okay, we've talked a lot about this ACE2 receptor, and what about patients who are on ACE inhibitors and ARBs? Should they take or should they not take these medications? And I'll spare you the details, but the bottom line was that according to just recently released information from the American Heart Association, the American College of Cardiology, and the Heart Failure Society of America, the bottom line is that patients with COVID-19 should continue to take ACE inhibitors and ARBs. So just so you know, that's a frequent question that arises. Okay, so let's talk a little bit about what we learned in China. I want to summarize some of the data from an analysis of the first 425 cases of COVID-19 pneumonia, not just general cases, but COVID-19 pneumonia patients in China. The average age of the patient was 59. A little more than 50% of the patients were male. The incubation period was 5.2 days. The R naught, this R with a 0 behind it, we'll delve into that in just a few minutes, was 2.2. So just hold on to that figure of 2.2 if you would. About half the patients were 60 years of age and older. Interestingly, no patient was less than 15 years of age. The median duration of illness onset from the time of onset of symptoms to when the patients first sought medical attention was 5.8 days. So now keep the math in mind here. So remember that the incubation period is 5 days. So they've been infected, 5 days goes by during the incubation period. Now they start to develop symptoms, and 5.8 days after that is when they first appear on average to seek medical attention. All right. The average time frame from onset of illness, again, the end of the incubation period, to the time of hospital admission was 12 days. Okay. All right. In another paper, when the viral loads, and viral loads is just nothing more, think of a viral load as a density of infection. So the viral load was compared with, for SARS-CoV-1 with COVID-19 with SARS-CoV-2. It turns out that for SARS-CoV-1, the viral load in the respiratory tract did not peak until 10 days after symptom onset. Why is that important? Because in retrospect, what that allowed us to contain the SARS infection was that patients, by the time they presented and sought medical attention because of symptoms, they still weren't very contagious. Yes, they had detectable virus, but they weren't too terribly contagious. They weren't excreting a lot of virus, let's put it that way. And so they immediately got placed in isolation and the infection got contained. On the other hand, with SARS-CoV-2, by the time patients come to clinical presentation, now roughly 10 days into their illness, they are quite contagious. And so by then, they've already spread illness and infection to other patients. So that's a key difference. That's why SARS-CoV-2 and COVID-19 is so much of a bigger deal than SARS is right now. That's a big part of that reason. The other things that we've learned from SARS-CoV-2 is that the viral loads, the density of virus tends to be higher in the nose than in the throat, although it is found in both places. And that in and of itself may be a way forward. Researchers have found, for example, that many viruses, and hopefully COVID-19 or SARS-CoV-2 is another example, but many viruses are susceptible and killed by plain old saline solution. So what's being looked at right now is whether having people who have been exposed to SARS-CoV-2, if they gargle with saline solution and use saline solution to irrigate their noses, would that help prevent them from getting COVID-19 infection? That's a very, very active area of research right now. So we'll see what comes to that. Wouldn't that be nifty if all it took is some saline solution to basically as a form of post-exposure prophylaxis? Already, one of the pharmacists, clinical pharmacists from here was telling me yesterday that she had seen in a listserv, an ID listserv, that in New York, healthcare workers already are being asked to do just that at the end of their shift or at the end of their day to gargle and use saline rinses in their nose. I'm not saying that we should do that here. I'm not saying that. But what I am saying is keep an ear to the ground for this, because I think there's going to be a lot more to come on that. In another paper from China, whereby they analyzed the first 1,099 patients, so this is a much bigger cohort than what we talked about a few minutes ago from Wuhan. The median age was about the same, 47 years. Again, a little bit more than 50% were male. 3.5% of them were healthcare workers. The most common symptoms for patients were fever. And this is kind of an interesting figure here. Only 44% of patients in this almost 1,100 patient cohort, only 44% of patients had fever on admission. Now, granted, 89% of them ended up with fever after they got into the hospital, yes, but only 44% had it on admission. So the point is that you can't count on the presence of fever. If they don't have fever, you can't say, oh, they don't have COVID-19 infection on admission. That's not necessarily the case. So that's an important point. And then 2/3 of patients had cough, usually a dry, unproductive cough. Diarrhea is uncommon. Why do we even mention diarrhea in passing? Because the virus has been found to replicate in stool, in the intestinal tract. The incubation period was a little shorter in this particular cohort of patients, 4 days. Lymphocytopenia is something that's been seen almost uniformly in all these patients. They have low percentages of lymphocytes in their peripheral smear, and the mortality rate was 1.4%. In another paper, also from China, and this is an important point to remember here, that when you think about COVID-19 infection, think about it in these terms. In short, what I tell people is the 80-20 rule. So just like, for example, with West Nile and Zika virus infections, it's the 80-20 rule, meaning that 80% of patients with West Nile and Zika are asymptomatic, 20% of people are symptomatic. The same is true for COVID-19. That's what we learned from China, that roughly 80% of people are either asymptomatic or mildly symptomatic. 15% of people are sick enough to be in the hospital, and another 5% are sick enough to be in the ICU on a ventilator. So remember that, 80, 15, and 5 as we go forward with this. So this is data from Germany, where they looked at a small cohort of patients, just 9 patients who were hospitalized in late January. All patients had been PCR positive for SARS-CoV-2, and then they measured the amount of virus that was found in their throat. And the viral concentration, the viral load was very high at symptom onset, which is in keeping with the thought that the virus replicates actively during the incubation period, so that by the time patients come to presentation, they've got pretty high viral loads. And that, on the one hand, that makes diagnosis fairly easy. because they've got a lot of virus at readily accessible sites. But on the other hand, the downside to that is that they can be already transmitting in fairly large quantities. Sputum concentrations declined more slowly, but continued throughout the first week of symptoms. The same is true for stool. And during the first week of symptoms, the percentage of patients with a positive viral culture. Now, again, this highlights the difference between PCR and viral culture. PCR detects virus whether it's live or dead. Viral culture only detects live virus. So only 16% of patients had detectable virus by culture in throat, but a significant percentage of them had it in their sputum. After day 8, so basically after the first week had gone by, although symptoms were clinically improving and the patients were clinically getting better, they still had relatively large quantity of virus detectable by RNA in throat, sputum, and urine, but no viral cultures were positive despite the ongoing high viral loads, implying at least that contagiousness had dropped off considerably by the end of the first week. So the conclusions of this paper, what I presented here to you was the result of that paper. The conclusions of the paper were that peak SARS-CoV-2 concentrations of virus, again, that causes COVID-19, were reached before day 5 of symptoms. Whereas with SARS, the viral concentrations did not peak until after 7 to 10 days of symptom onset. That's a key difference. Interestingly, too, the peak concentrations of SARS-CoV-2 were at least 1,000 times higher than SARS-CoV-1. So much, much more virus was found in COVID-19 patients than in SARS patients. Throat cultures would suggest the presence of virus in throat cultures suggests active viral replication in the upper respiratory tract. And that gets back to what I just said about a few minutes ago about active viral replication in the upper respiratory tract. Maybe, just maybe, that'll be a path forward for us with the use of the saline rinses. So again, stay tuned. And then the last lesson from Germany that I wanted to mention was a case of asymptomatic transmission. In other words, transmission during the incubation period. In brief, this was they described a case of a 33-year-old healthy German businessman who became ill with sore throat, chills, and myalgias on January 24th of this year. The next day, he developed fever to 39 and a productive cough. He felt better, though, and returned to work 3 days later. Ugh. But before the onset of symptoms on January 24th, he had had a meeting with a female Chinese business partner in Munich on January 20th and January 21st. As the Chinese woman was flying back to China, she became symptomatic with COVID-19, and upon return to China, she was indeed showed to be positive for COVID-19 infection. So it appeared that she, although when they met, she was asymptomatic, but she appeared to give this German businessman a case of COVID-19 infection while she was still incubating. So again, the takeaway here was that the transmission during the asymptomatic incubation period keeps with the high viral loads that are seen at the onset of symptoms. Radiographically, these are two CAT scans here from Wuhan, China. This is a 29-year-old man who had fever and cough and ultimately required a stay in the ICU. And the white arrows shown here are ground glass infiltrates, and then the black arrows show confluent consolidation here. And if we go to the next slide, what's interesting too is that a lot of the lung pathology seems to be in the periphery of the lungs as opposed to the central part of the lungs. We don't know why that is, but that seems to be the case at the moment. Another interesting thing about COVID-19 infection is that roughly, anecdotally, it's been reported that roughly about a third of patients with proven COVID-19 infection lose their sense of taste and of smell right at the onset of their symptoms. How long that lasts, we don't know. It seems that it comes back, but it may be tied in with all the viral particles that are found in the upper respiratory tract at the onset of illness. But it is kind of a clue, if you will, a clinical clue, when patients present with nonspecific respiratory complaints, if they're telling you that they've lost their sense of taste or sense of smell, that to me would be a warning sign that they may have COVID-19. So what have we learned from the CDC among cases in the US? So this is data through basically a month's worth of data from mid-February to mid-March of this year. And this bar graph here at the top here shows, as you might predict, that in dark blue, the number of deaths is higher as patients get older in age. That's no big surprise there. But I think what's very telling about this slide here is the number of hospitalizations and the number of ICU admissions is pretty steady across the board, despite the increasing in age. The point is that young people in their 20s and 30s still can very much end up in the hospital and in the ICU. It's not just all confined to the older age groups. Here at the table at the bottom is the case fatality rates by age. And to summarize here quickly, you can see that the case fatality rate does not jump above 1% until patients get to be 55 years of age and older. As long as the patients are less than 55, their mortality rate is less than 1%. But once you get above 55, then the rates start to go up. And then the other thing that, of course, that factors into that is how good a shape they're in immunologically. Do they have diabetes? Are they on biologic agents? Do they have cancer? Those kind of things, because all those would be additional risk factors to heighten their risk for mortality. So in Missouri, current testing now is that, according to the state is willing to test hospitalized patients who have compatible signs and symptoms of COVID-19 infection to permit infection control decisions. Outpatients who meet criteria for influenza testing can also be tested. Those adults greater than 50 years with diabetes or chronic diseases, immunocompromised hosts, pregnant women, symptomatic children, those will be tested as well. And healthcare workers who are within 14 days of the onset of symptoms and had close contact with a suspected or laboratory confirmed case of COVID-19, or who have a history of travel within the previous 14 days. Now, almost anywhere internationally, not just China. Specimen requirements, most often what's used is a nasopharyngeal swab placed in viral transport media, and both the swabs and the viral transport media have been in short supply. That's why testing has been limited and hard to come by in our area, mainly because that's where the bottleneck occurs, is not having enough swabs and viral transport media to put the swabs into to get them to the lab. Sputum can be collected as long as it's not induced, because coughing and inducing sputum is just going to aerosolize virus and make them that much more transmissible. So unless we don't ever want to induce sputum sample from COVID-19 patients. So let's talk a little bit about transmission and droplets. We talked a few minutes ago about all those viral particles that are produced in the lung, those millions and millions of viral particles that are released. And they end up being enveloped, if you will, in mucus or saliva within the lung. And that sandwich, if you will, is termed a viral droplet. And then these viral droplets are ejected, shown here elegantly in the picture, from the mouth or nose when the person coughs or sneezes or laughs or sings. Humorously, I read where if you're talking to another person and you can smell the garlic on their breath, what they've had for lunch, you're standing too close, so back up. So when a person is infected, shown here on the left, they are excreting respiratory droplets like we just talked about. And those droplets, can be transmitted in the air for a short distance over 3 to 6 feet. Not all the way across the room. Why? Because the droplets are too big, too heavy, and they fall harmlessly to the ground. But if I'm infected, for example, and I cough or sneeze into my hand, and then I go and shake your hand, bingo, I've just given you COVID-19 infection. If I'm infected and if I'm coughing and sneezing in my bed, and you come along and you touch my bed, bingo, you've just acquired COVID-19 infection. The other way that you can do it is transmit it is through aerosolization into droplet nuclei. And we can talk about those differences here. So, pardon me. So, droplets, as we said, are relatively large, at least 5 micron collections of secretions. they remain suspended in the air for a short period of time. And some examples of, other examples of droplet infections that are transmitted by droplets are Neisseria meningitis, influenza, every year that we see. When patients come in with flu, they're put in droplet isolation. Mycoplasma and SARS, there's all transmitted by droplets. Okay. On the other hand, smaller particles, droplet nuclei, which are basically kind of, think of it as evaporated viral particles where the mucus and the respiratory secretions kind of dries up, so you're just left pretty much with the viral particles, or found in dust. They can be inhaled because they remain suspended in the air for a much longer period of time, like TB, and they can be, and because they're so small, they can end up easily in the terminal reaches of the lung, into the alveoli, deep in the lung. So TB is the prototype that's transmitted by airborne transmission. Varicella chickenpox is another example. Disseminated zoster, measles, and Legionnaire's disease are all transmitted by airborne. I want to just briefly mention in China, a cluster of 11 patients that were investigated at a shopping mall. All 11 had tested positive for COVID-19. Most, but not all, case patients denied direct close contact with one another. And viral spread via fomites, inanimate objects like elevator buttons, for example, or virus aerosolation in confined spaces, such as restrooms or elevators, could not be excluded. SARS-CoV-2 virus nucleic acid, not live virus, but the nucleic acid, was detected on a doorknob at a patient's house. The conclusion was that low-intensity transmission occurred without prolonged close contact. So there are these case reports here and there of transmission by inanimate objects and fomites and whatnot, elevator buttons and doorknobs and so forth, but they're fairly few and far between. This is a very small minority of the cases of transmission, at least it seems to be to this point in time. And the reason that we mentioned earlier, the fact that virus SARS-CoV-2 also replicates in the intestinal tract, that led the FDA this past week to issue a safety alert to warn providers and patients about the potential risk of transmission of SARS-CoV-2 in fecal transplants that are used for C. difficile, to treat C. difficile patients. So yet another complication of SARS-CoV-2. Okay, so let's talk a little bit about the use of masks that are so pervasive right now. We've seen them for months now on end in China and other countries, so let's talk a little bit about that. So the common blue or yellow mask that we use so much, that we've used for years now for droplet precautions, these, as you know, are loose-fitting, and they're not designed to be shared or reused. They prevent the exhalation of infectious particles, but because they're loose fit, they don't prevent incoming particles from being inhaled. So they're good at helping to prevent transmission exhalation, but they're not good at keeping infections in the air out. To an extent they will, but not great. Because why? Because they're not tightly fit to the face. So they're useful for preventing an infected person from transmitting infection to other uninfected persons. They're not helpful, however, in preventing an uninfected person from becoming infected by virtue of the loose fit. They're not fit tested. So there's that gap. Okay. So in contrast is the airborne precautions, where we use the N95 mask. And the N95 gets its name because it's able to filter out at least 95% of small 0.3 micron particles out of the air and prevent acquisition in that way. And because they're fit tested, there's a tight seal, in other words, around the nose and mouth, they're much better at preventing the inhalation of infectious particles in the air than are the surgical masks that we just talked about. So annual fit testing is key here for this. Again, like the blue masks, they should not be shared or reused, preferably. They're helpful to prevent uninfected persons from becoming infected. So if you have a TB patient, for example, you're going to be putting on an N95 mask because TB is aerosolized and airborne, and you're trying to prevent you yourself from acquiring airborne TB. They're not helpful, however, for giving it to a hospitalized patient because the patient hasn't been fit tested, And second, because it's an important waste of resources. Yes, they'll trap, if the mask was fit tested even to the patient, yes, they would prevent the exhalation of infectious organisms from the patient, but it's a tremendous waste of resources when a simple blue surgical mask would suffice. So if we saw a COVID-19 patient in the hospital, here's what we would do. Airborne isolation, contact isolation, and eye protection, meaning that, to break that down a little bit, a private room with negative air pressure, 6 to 12 air exchanges per hour, the use of a non-sterile disposable full-length gown, non-sterile gloves pulled over the sleeves, a fit-tested N95 respirator or a powered air purifying respirator, a PAPR, goggles and face shield. Why? To prevent droplets ending up in your eyes when another person coughs or talks. And hand washing for 20 seconds or alcohol hand gel with 60% alcohol. Patients can come out of isolation when they have 2 consecutive negative RNA tests collected at least 24 hours apart. So this is a picture taken from an ICU in China. You can see everyone is all garbed up here in their what they need here. You can see the face shields here and the masks and so forth. The process of intubation, in and of itself, intubation can lead to aerosolization of virus, so that can be a very infectious time. But once, on the other hand, the patient is intubated, then now you've got source control of the infection, and that lowers the risk of transmission. So a patient lying there in bed on a ventilator is going to have a much lower risk of transmission compared to, say, a non-ventilated patient, for example. BiPAP is an aerosol-generating procedure, and so patients on BiPAP are at increased risk in contrast to the ventilator. BiPAP patients are at increased risk of transmission, so in that case, PAPRs for everyone would be recommended. Okay, here's the part to make you smile. I thought this was kind of cool. Fanatics, a company based in Easton, Pennsylvania that normally makes baseball uniforms. There's no baseball being played these days, so they've got creative, and they started making PPE material. Whether they make gowns like this in royal blue, I don't know. But I thought that was kind of a neat way to kind of handle this with the time on their hands. And they've said in their press report that they've got lots of material to use. So that's, I thought, very encouraging. So yeah, so we'll see what comes of that. So to summarize some thoughts about transmission for COVID-19 for SARS-CoV-2, most transmission can be accounted for by close association of people when they come together within 3 to 6 feet, implying that droplet transmission is much, much more important than transmission by inanimate objects like doorknobs and elevator buttons, for example. The virus survives within droplets to a certain degree, but how long is really not terribly important because the droplets don't hang in the air very long. They quickly fall to the ground. Yes, cases of unusual transmission patterns can occur, as we talked about, but those are relatively rare. Routine environmental cleaning with virucidal agents helps reduce the risk of transmission on environmental surfaces. A key driver of the infection, though, of the pandemic these days, I think, is asymptomatic infected persons who then have close contact with others. They feel well, they don't feel sick, and so there's no restraint, there's no mitigation efforts going on, and so they can transmit, many times at high viral levels. It's important for healthcare workers to prevent their own mucosal surfaces from being inoculated, so wash your hands and use PPE. Probably a good idea, be interested to see what Villain says about this, but probably a good idea from what I've read and what's going on in New York right now for healthcare workers at the end of their shift or at the end of their day to go home, wash all their clothes, put them in the washing machine, and then take a shower as soon as you come home. And the whole idea then, as we said, about gargling with saline is maybe another consideration as well. And hopefully with more widespread testing, that'll permit us to better use our limited PPP resources. Okay, so now we get into the more troubling parts of the talk. How worried should we be? And in order to answer that question, we have to talk about something called the reproductive number, or R naught. R with you can see a 0 subscript. And simply put, the R naught refers to the number of infected persons to whom let me start again. The R naught refers to the number of uninfected persons to whom an infected person would transmit. So in other words, if you locked 20 healthy, uninfected people in a room and had an infected COVID-19 patient walk into that room, the question is, how many patients are going to acquire their infection? If the R naught is less than 1, transmission to others is unlikely. If the R naught is greater than 1, transmission to others is likely, and the epidemic will perpetuate itself. So if the R naught, and remember I said in an earlier slide, I told you to hold on to this number, the R naught was for COVID-19 was 2.2. So if the R naught is 2.2, or let's say 2, that one person infects 2 people, and then those people infect 2 more people, and you can see how it's kind of like compounding interest. The numbers quickly escalate. The doubling time in China had been 4 to 5 days. The doubling time in New York City recently had been 3 days. So that's how fast this can multiply. Next. So the R naught for COVID-19 is roughly about 2.2. For comparison purposes, for flu, it's 1.3. So meaning that flu is less contagious than COVID-19. Measles is far more contagious than either one. The R naught for measles is anywhere between like 12 and 18. So way more contagious. Measles is one of the most contagious of all infectious diseases. Ebola is 2. So you can see some other examples here. So this is where it gets a little concerning. Back in the early part of March, there was an article that appeared in the New York Times where a New York Times journalist had a sit-down conversation with a mathematician from the London School of Tropical Medicine and Hygiene. And this gentleman from London is a mathematician who specializes in infectious epidemics and epidemic curves. And so the question was asked of him at the end of that interview by the journalist, so what should the average Joe be concerned about with all these numbers that you're telling us about? How would you use that information? And here's his response. He said, when in your area, whenever you have the first severe case or the first death from COVID-19, think about what that means. The average mortality rate for COVID-19 is 1%. And if there's a death today from COVID-19, that means that patient became ill roughly about 3 weeks ago. So that means that 3 weeks ago, there was 99 other patients who also had COVID-19 because only 1% of them died. So that meant there were 99 other cases already 3 weeks ago. And then during the subsequent 3 weeks, those 99 cases could have doubled, then doubled, then doubled again. So that by the time this person dies, you're looking at 500 to 1,000 other cases in the community. That's what that means. Yeah. Another way to look at it, without any mitigation efforts, now again, understand we're talking without any mitigation efforts at all, the R naught of flu, as we said, is 1.5. Roughly about 1% of seasonal flu patients must be hospitalized. So over 2 months, a single patient with flu can infect 386 other people, and a handful of those would have to be hospitalized. Again, that's in the absence of any mitigation efforts. On the other hand, with COVID-19, the R naught is 2.2. Roughly, as we said, the 80-20 rule, 20% of COVID-19 patients must be hospitalized. Over 2 months, a single person with COVID-19 can infect 99,000 other patients. That's why this is spreading like it is. Again, in the absence of any mitigation efforts. And 20% of those would have to be hospitalized. That's why it's such a big deal. This is a chart to kind of allow you to kind of compare visually how these different infections stack up. So mortality goes up here, and then the contagiousness goes here from left to right. So you can see here's the COVID-19 here. It's just kind of a range here because it's kind of a bit of a moving target. So as we said, both SARS and MERS have higher mortality rates than COVID-19. And Measles is much, much more contagious than COVID-19, but still, COVID-19 is much more concerning than just seasonal flu as well, or the common cold. So it just kind of gives you a feel for where this stands, COVID-19, relative to some other common infections. Now, what happened aboard the Diamond Princess? Remember that the Diamond Princess was that cruise ship that eventually ended up in Yokohama, but there was 3,700 people on board that ship, and nearly 20% of them had coronavirus, COVID-19 infection, including 43 Americans. There were 3 deaths. And the index patient, the patient that, if you will, started all this on board that ship, was an 80-year-old man from Hong Kong who got off the ship and then got tested in Hong Kong and was positive. At that point, Hong Kong health officials emailed the Princess Cruise Line physician in California. He was not on the ship. He was in California in radio contact with the ship. And they told him, the Hong Kong official told him that this passenger had tested positive for COVID-19. That sat unread in his inbox for 2 days. While that was happening, patients were transmitting on the ship. When that happened, when it was learned that this patient had tested positive, there was some mitigation efforts put in place, but not nearly, in retrospect, enough. So on the one hand, passengers were told to stay in their room and the crew would bring them food, which they did. But the only problem was when they handed them their food, they used gloves, and they used the same gloves for this person and for that person and for that person, all they went down the hall. So they just used the same pair of gloves. And they opened the door, "Hi, how are you? Here's your dinner tonight." And there was just face-to-face contact. So again, well within the range of droplet transmission. Buffets remained open as usual. Opera performances continued. Goodbye parties continued, all unabated. There was no immediate contact tracing. And kind of a twist of irony, at when the day that the Diamond Princess pulled into Yokohama, there were new cruise ship guidelines that very day that recommended that close contacts of a confirmed case should be evaluated and quarantined on shore, not on the ship, but on shore. And instead, the Japanese government asked passengers to stay in their rooms while awaiting test results. During that time, passengers continued to move about and eat at buffets. So it just facilitated that transmission that much more. So is it any wonder that there was that percentage of people that were infected? Probably not. So in late February, the CDC confirmed the first possible community transmission. It seems like it's way longer than a month ago. I don't know what it does to you, but it seems to me like it's just a month ago. But the first possible community transmission of coronavirus in the US in late February. And then on February 29th, the US announced a radical expansion of coronavirus testing. A very telling figure in this article released in the New York Times was that as of February 29th, the CDC had tested in the US total, less than 1,000 patients for COVID-19. And at that same time, South Korea had been testing 10 to 15,000 patients a day. So we got way behind in testing. And that's why, now the US leads the world in the number of cases. Next. So this ID Now test, this rapid point of care test by Abbott Laboratories that was just approved by the FDA last Friday, brings now point of care testing available. And my understanding is that starting tomorrow, April 1st, the Abbott Labs will make the test available 50,000 at a time on a daily basis. I'm sure this will go to hot zones around the country for right now to get people tested, but we have requested some here. According to Dr. Turner, we have requested some here. So keep an eye out for that. So that'll make testing, and especially drive-up testing, I think, a lot easier to accomplish. So just some examples of drive-up testing. So again, we're hoping that that could really improve our ability to do drive-up testing here locally in the community once we have a test like that available. What about serology? And by serology, we're talking about the measurement of IgM and IgG antibodies in blood. Serologic markers will likely turn positive later than virologic markers. They're important in retrospect in learning about the extent of disease, the extent of infection in a particular cohort or particular population. But as far as point of care testing or management of acute patients in real time, these tests are not really overly helpful. So again, they're helpful to diagnose in retrospect, not so much helpful in real time going forward with the day-to-day management of patients. Can immunity develop? So that's a question that comes up is, and we alluded to this earlier in the talk, does infection result in immunity, and if so, for how long? Is it lifelong, like it is for polio and measles, for example, or is the immunity very transient, like it is for colds and flu every year? We don't know that yet. And the follow-up question is, does asymptomatic or mildly asymptomatic infection, like the 80% of people, confer immunity? Are they as immune, if you will, as patients who have symptomatic infection? So we'll have to see how all that plays out, but those are just questions. Now, a couple words about treatment, and there's not a lot to say here because there's no FDA-approved treatment for COVID-19 at this point in time. By far, the best results so far in preliminary trials have been with remdesivir. Remdesivir is an antiviral agent that was initially developed for Ebola back about 5 or 6 years ago. It failed, but it seems to have quite a bit of activity against SARS-CoV-2. It's also active against other viral infections like RSV and Marburg and so forth. It's given only by IV. There is no oral route available. There is currently a randomized double-blind placebo-controlled trial going on in hospitalized patients in St. Louis and also up in Omaha, Nebraska. But in order to participate in that trial, patients must be under their roof. We cannot have patients here and they send us drug here and then we do the test and then send the results to Omaha or St. Louis. It doesn't work that way. Patients have to be under their roof in order to qualify for the clinical trial. Remdesivir is available by compassionate use directly from the manufacturer Gilead, but only for pregnant women and children less than 18 years of age. That's it. We're looking into see if there's any other clinical trials that are available right now. We just had a conversation about that yesterday. The ACE2 idea and blocking ACE2 receptors, there's theoretical considerations in both directions whether blocking the ACE2 receptor would be helpful or harmful. There's no hard data yet. So future studies, future answers to that question will likely be observational, but not through randomized controlled trials. Hydroxychloroquine, as you know, was approved yesterday by the FDA for use, although the data I think is pretty soft. There was just recently, within the last 5 days, there was a small trial reported out of China among hospitalized patients comparing hydroxychloroquine alone with standard of care. 15 patients in each arm, so a pretty small study, showed no significant difference in outcome. Azithromycin was not used. Sometimes azithromycin has been given with hydroxychloroquine. Azithromycin, after all, is an antibiotic. It's going to have activity against bacterial agents, but not against viruses. Why would they even use azithromycin? Because of its anti-inflammatory properties. It's got ancillary anti-inflammatory properties that may have some benefit in the lungs, although that's very much debatable. And yesterday, I was reviewing the current treatment guidelines put forth by the University of Washington. The University of Washington, you'll recall, was the epicenter for many weeks of COVID-19 in the US until now that distinction was taken over by New York City. But they specifically advise against the use of hydroxychloroquine and azithromycin. They don't think the evidence is there to support it. Lopinavir, Kaletra, is an HIV drug. There was an open-label study done in China, not placebo-controlled. There was little decrease in the amount of detectable virus. Not really the first thing to be reaching for. Again, lopinavir is on the do not use list, basically, by the University of Washington. So no surprises there. There's at least 20 vaccines in development right now. And interestingly enough, too, in China, there's at least 2 patients that I've read about that have actually undergone bilateral lung transplants because of severe and overwhelming COVID-19 infection. So the best way that we have right now to prevent infection is to avoid exposure, and that's through washing your hands like we talked about the soap, again, disrupting that outer lipid envelope of the virus and inactivating it. If you not using your fingers to rub your eyes or nose or mouth, because that's a way to just auto-inoculate your mucous membranes and basically give yourself an infection. Good cough etiquette, coughing into your elbow like that, and social distancing, which is really what we're all about today. That's what, I mean, we're all a bit into social distancing right now. So what's going on in the coast right now in New York and initially going on in Washington, basically because they didn't have time to prepare or have mitigation efforts in place, you're seeing this huge surge of cases that is overwhelming. The dotted line here represents the capacity of the healthcare system in that region. And so in those places, those hotspots, if you will, without adequate time to prepare and have mitigation efforts in place, they have these huge number of cases like this. On the other hand, we're fortunate living where we do in the Midwest because it gives us time to prepare and put mitigation efforts in place. And with that, not only will the number of cases be nothing like what it is on the coast, but I think it'll also delay the time until it finally gets here as well. So one of the questions that comes up frequently in these discussions is, well, what do you think we're going to see here in River City, in St. Joe, Missouri? What are we going to see? So this is a map of the continental U.S. on the New York Times website. Basically, this is a mathematical model offered, and you can pull up any county in the U.S., any county, with either no transmission, no mitigation efforts, some mitigation efforts, or severe mitigation efforts. So just for kicks, I plugged into Buchanan County with moderate mitigation efforts. And as you can see here, what they're projecting for us is that there'll be 300 cases in Buchanan County. Most of those they won't all be in the hospital. Most of them will probably actually be home quarantine at home. Not all, but we'll see some here for sure. But I would guess that most of those will be quarantined at home. But the prediction as far as the peak is not until late June. Think about that. That's 3 months from now. So this is not going to go away anytime soon. We're going to be with this for a while. My own personal thought is that we'll be lucky if we start to get this in the rearview mirror by around the 4th of July, if we're lucky. So we'll see. But now if we do even better with mitigation efforts, those numbers would be less. So it's important that we use every day that we have right now to keep preparing and keep social distancing as much as we possibly can to flatten that curve. Is there a silver lining in all this? Actually, there is. So these are NASA satellite images showing the amount of nitrogen dioxide, NO2, in the air. Basically, think of it as air pollution. And so this was early January of this year. You can see there was a lot of yellow and red here, implying a lot of air pollution in China. And then when the infection took hold and people stopped working because of mitigation efforts, you can see that a lot of the pollution went away. In January, this is in Wuhan, in January of last year, 2019, the red is the pollution areas. And then when this was in early January of last year, then when the Chinese New Year occurred and they were on holiday, then the pollution got less. And then after the holiday was over, the pollution picked up again. This year in 2020, here was the air pollution in early January. Then the holiday came, and then COVID-19 hit. So the pollution went away, and because of COVID-19, because people weren't working in the factories, the pollution stayed away. So there was no rebound in the pollution. So that was interesting. These are some additional resources. You need to burn this number in the back of your brain. The Hospital Incident Command System that Verlaine and Danielle and a whole multitude of administrative people here at the hospital have done just absolutely yeoman's job in answering your questions and concerns and worries about this and how to deal with patients, how to get patients tested, what isolation procedures to use and whatnot. I think we need to be having Verlaine donuts here before long. This is an additional resource. I would strongly suggest that you take a look at this. This is from the University of Washington's website. Here's the site, covid-19.uwmedicine.org. And this is a page. These are some of the hyperlinks here available on this page. And the hyperlinks are just really very, very well done. But this is all based on practical experience. That's what's so nice about this. Other centers have resources like this out there, but they don't, because they haven't seen the number of cases anywhere near like they've had in Washington, their experience is limited. But here, this is very practical information. How to deal with, for instance, immunocompromised patients, how to deal with pregnant patients, when healthcare workers can go back to work. All those kind of things are dealt with, I think, pretty nicely in here. So it's worth a look-see, I think, to peck around on that website. This is just one example. This is the testing page. But you can see how well done this is. In case you have questions about what chemicals to use to wipe off a tabletop or a doorknob or something like that, what will effectively get at SARS-CoV-2, the EPA has a website. It's worth taking a look at that. And they've got a listing of approved products for COVID-19. So take a look. Mayo has a variety of resources as well. Just complementary resources, so these are pretty good. This is one example from Mayo. This is some guidance on how to reuse PPE equipment, N95s and face shields and so forth. So just some nuts and bolts kind of practical advice so we don't have to reinvent the wheel. Next. So final slide here is the big picture. Over the next few weeks and months, I think the focus here, both in St. Joe and across the country, is to isolate and contain infected persons and to prevent further spread through social distancing, or as Dr. Fauci called it, hunkering down. Over the next 1 to 2 years, to develop antiviral therapies. Again, I think by far remdesivir is the leading candidate right now. Preliminary studies and trials show it to be pretty effective. And hopefully to develop widespread immunity through either vaccines or herd immunity. Remember that the 80% rule, the 80-20 rule, so if 80% of people who get this infection are asymptomatic, then they'll have antibodies and that'll prevent them, hopefully, from becoming infected should they be re-exposed in the future. And then long term, over the next 2 to 5 years, hoping, with fingers crossed, that human-to-human transmission will peter out in the same way like it did for SARS. I don't know, that may be a long shot. We'll see. So thanks for your attention today. And through all of your efforts, we can get through this together. But now more than ever, my parting words to you is that now more than ever is when our community really needs our best efforts. So thank you again for your attention.